Good evening, everyone. Once again, welcome to G Echo. This is a program that's hosted by the Gastro Foundation in association with Project Echo from the University of Mexico. And today we have with us a fellow from Curtis Hospital, Dr. Muaz Moosa, who's going to give us a presentation on colorectal cancer. Just to note that the chat will be open for any questions, and we hope to have an interactive discussion thereafter. Muaz, over to you.
Thank you. Thank you for the opportunity. I'll share my screen now. Can you?
We can see your screen.
Okay, Muaz, you may proceed.
Yes, hold on. Okay. All right. Hi, good evening, everyone. Today we are going to talk about colorectal cancer. I think this is a very important topic, given that this is the most common gastrointestinal cancer that we deal with, and it actually refers to the cancer of the colon and the rectum. This is also the third most common malignancy overall. There are different types of cancers in the when we mention colorectal cancer, there are different cancers as well, but adenocarcinoma is the most common type of colorectal cancer, which accounts for around more than 90% of all cancers. And adenocarcinoma of the colon is also the most common gastrointestinal cancer as well. Overall, there is a good prognosis. 5-year survival is around 90% if it is diagnosed early on. However, unfortunately, only 40% of the patients are diagnosed when the cancer is still localized. So we need a lot of work done in terms of identifying patients early, screening as well, to ensure that the good prognosis is there. In terms of epidemiology, as I mentioned, this is very common. This is the most common cancer of the GI tract. It is also the third most common diagnosed cancer in male, as well as the second most common cancer in females, according to the WHO Global Cancer Database. The incidence and mortality are higher in the male compared to female. As we age, the incidence or the risk of cancer increases, and the median age of diagnosis is about 70 years. The incidence and mortality rates of colorectal cancer exhibit substantial geographical variation, largely probably related to the lifestyle changes or environmental factors that are associated with the disease. As you may see in this graphics, this is you can see that the highest incidence of colorectal cancer are seen in the Western world, in the Europe, America, as well as Australia and New Zealand. The lowest incidence is seen in countries like South Asia and some parts of Africa as well. Similarly, when we look at the mortality rate, the highest is seen in the Europe as well as some parts of Africa and North Asian countries. There are various risk factors identified in various epidemiological studies. It's consistently, the male sex as well as increasing age has been shown to be associated with colorectal cancer. There are both hereditary as well as environmental factors which have been identified. We'll look more closely to them. Looking at non-modifiable risk factors, as I mentioned, age is the most common associated with risk factor, especially if those who are older than 50 years. More than 90% of the colorectal cancers occur in patients who are aged more than 50 years. If somebody is age 50 and if the person ages until 80 years, there is a risk of around 5% of developing the cancer, or the 2.5% risk of dying from a colorectal cancer if the person ages to 80. Similarly, as we mentioned earlier, the incidence is higher in men compared to women, and then it's also more seen in the high-income countries compared to the lower-income countries. But everywhere, the male-to-female ratio is higher. Other factors include the genetic factors. There are various genetic factors like hereditary associated with the hereditary colorectal cancer syndromes, the most common being the familial adenomatous polyposis syndrome as well as a Lynch syndrome. But even though they are the most common hereditary syndromes, they account for only 5% of the colorectal cancers. Similarly, apart from the hereditary syndromes, there is also other familial associations. If there is a history of colorectal cancer in the family, then the people are at risk of developing colorectal cancer, especially if there is first degree relative. The relative risk is around 2 to 4. If the family history, among the patients with colorectal cancer, it is approximately 15 to 20% of the patients are in sporadic cases as well. There is a familial association, even though they do not fall into the hereditary cancer syndromes. Other factors include abdominopelvic radiation. People who had radiation, like prostate cancer, or for any other reason, if they have received radiation, then they are at increased risk of developing colorectal cancer. Hence, these patients should be screened regularly, or if there are symptoms suggestive of early colonoscopy should be done. Other personal history of the disease is like if the patients have inflammatory bowel disease like ulcerative colitis or Crohn's, as we know that these conditions are associated with colorectal cancer, if supposing the extent and the duration of the disease and the control of the disease. Certain other conditions like diabetes or metabolic syndrome and is related to the insulin resistance, which related to the which stimulates the tumor growth, and then other conditions like cystic fibrosis, renal transplant, and coronary artery disease are also associated with colorectal cancer. Other important factor is gut microbiota. It's noticed that there are changes in the gut microbiome with a reduced diversity in patients with colorectal cancer. So there are certain organisms identified like Fucibacterium nucleotum, Streptococcus galotium, or previously known as Streptococcus bovis, and H. pylori. So there have been some association, but we are not sure whether this is as a result of the cancer or because of these changes the cancer is. But a lot of research is ongoing. Potentially, probably we will have some implications with the research in modulation of or prevention of the colorectal cancer as well. At the moment, also some researches are ongoing in FMT is a potential area of therapy for especially MSIH and DMMR colorectal cancers, metastatic cancers who are resistant to the checkpoint inhibitors. In terms of looking at the modifiable risk factors, like alcohol consumption has been strongly associated with the positive, especially in the heavy drinkers who drinks more than 50 grams per day. The risk is linked to the DNA methylation that affects the gene expression. Similarly, smoking has been consistently associated with the colorectal cancer, probably because of the exposure to carcinogens, and some other as well as a long-term exposure causing genetic changes in the colorectal cancer as well. Similarly, if there is a reduced risk of, if the smoking, there is a reduced risk if the smoking is stopped, and some hypothesis is that even smoking changes the gut microbiome, so hence that is also one of the effect of smoking as well. Other factors include the obesity, direct link to the obesity via the pro-inflammatory cytokines, interleukins, as in TNF alpha. Also, because of the insulin resistance, there is a rise in insulin as well as IGF, which promotes tumor growth, and also association with the increased bile acid levels causing inflammation. Other risk factors include the sedentary lifestyle, low physical activity leading to at least 30 to 50% increase of, or active lifestyle reduces the 30 to 50% of reduction in colorectal cancer. The mechanism proposed is actually with higher obesity, glucose levels, insulin resistance, as well as abnormal intestinal peristalsis because of the sedentary lifestyles that leads to the colorectal cancer. Again, other factor is unhealthy diets, especially high intake of red or processed meat, as well as fat intake. Those who take a higher intake of red meat as well as processed meat, they are at increased risk of colorectal cancer. Also, cooking at a high temperature, which leads to the production of heterocyclic amines, which can be carcinogenic. And then there is a mixed evidence regarding the dietary fat, but some association is there with the increased intake of fat in the development of colorectal cancer as well. The other important thing is actually psychological stress, which suggests that whether our work-related or whatever the stress that we may have, which may increase our risk of colorectal cancer, apparently 36% in some studies. Some mechanisms that are proposed include overactivation of the hypothalamic pituitary adrenal axis leading to immune impairment, abnormal metabolism as then leading to the cancer. However, the more research is needed because given the inconsistent findings in these areas. This diagram gives a summary of the risk factors that are associated with the colorectal cancer. So the other important thing that is needed to be highlighted is even though age is a risk factor, there is increasing incidence of colorectal cancer in the younger group, meaning those who are younger than 50 years of. If there is a development of colorectal cancer, that is the entity called early onset colorectal cancer. This accounts for around approximately 10% of all newly diagnosed colorectal cancer. What is important to highlight is actually, even though patients are young, premorbidly well, the mortality rate as well as, prognosis is poor in this age group. Hence, these cases need to be identified early on, given that most of the time the cases are diagnosed at a later stage as well. It is estimated in the next 10 years, actually, that 25% of rectal cancer, as well as 10 to 12% of colorectal cancers will be diagnosed in the younger patients who are younger than 50 years of age. And some estimates around by 2030, there will be increase in 90% of increment of colon cancer in this group, as well as around 125% increment of rectal cancer in this age group. There are some clinical phenotype, some differences in terms of the presentation or their behavior compared to the late onset colorectal cancer. The most common presentation is in the rectum, followed by the distal colon. Approximately more than 70% of all cancers in this age group is in the left side of the colon at presentation. And however, compared to the late onset colorectal cancer, the frequency of left-sided and the right-sided is somewhat similar in the elderly population. Some other interesting thing to highlight is actually higher rates of poorly differentiated cancers with those with signature ring cell among patients with the early onset colorectal cancer, particularly in the patients who are younger than 40 years of age, than compared to the late onset colorectal cancer. So this, summarizes the risk factors. So it is hypothesized that multiple risk factors are interrelated. The patient's genetics, sex, dietary, and the lifestyle exposure over decades that interact with the other risk factors, and then change in gut microbiome and the dysbiosis that lead to the chronic inflammation and ultimately leading to the development of colorectal cancer. So looking at pathogenesis of colorectal cancer. Colorectal cancer is caused by colon's aberrant proliferation of glandular epithelial cells. It's a complex multi-step process that involves genetic as well as epigenetic alterations that lead to transformation of the normal colon epithelium to the malignant tumors. There are principal three types that are involved in the colorectal cancer. That is the sporadic colorectal cancer and hereditary colorectal cancer, as well as the colitis-associated colorectal cancer. These different types of colorectal cancers develop from usually starts with a benign adenoma, which then advances into cancer, subsequently metastasizes via different pathways. The two major pathways that are identified are the traditional adenoma carcinoma pathway, also referred to as chromosomal instability sequence, that accounts for 70 to 90% of the colorectal cancers, and the serrated neoplasia pathway, which accounts for 10 to 20% of colorectal cancers. They have distinct multiple genetic and epigenetic events that are rather sequential in order. So looking at chromosomal instability phenotype, that is also called adenoma carcinoma pathway. As I mentioned, it accounts for around 70 to 90%. This can be either familial adenomatosis polyposis syndrome or sporadic cancers. It starts with the initial event being the APC mutation, then subsequently RAS mutation activation and functional loss of TP53, ultimately leading into microsatellite stable colorectal cancer. Then the next pathway is a serrated neoplasia pathway, which is associated with the traditional serrated as well as sessile serrated, which accounts for 10 to 20%, which initiates with a RAS and a RAF mutation and subsequent epigenetic instability characterized by CpG island methylation phenotype. This leads to the microsatellite stable as well as unstable cancers. And then comes the microsatellite instability or MSI, which is the Lynch syndrome, which accounts for 2 to 7% of cancers. But this can also occur in around 15 to 20% of sporadic cancers as well. This starts with a germline mutation in MMR genes, which uneven replication of the repetitive DNA sequences in short non-coding regions called the microsatellite, and increased susceptibility to additional gene mutations. That subsequently leads to microsatellite unstable colorectal cancers. This is a summary of the sequence of from normal epithelium to benign polyp, subsequently adenoma, and then late development and subsequently cancer, and then metastasis over decades. So there are some difference if you look at the left-sided versus right-sided. Apart from the anatomical difference, there are some aspects that are important. Being the right-sided cancers are midgut derivatives, and then left-sided are originate from the hindgut embryologically, and more common in the men. And overall prognosis is better in the left-sided disease. And however, on the other hand, on the right side, which is more common in the women, and it has more sessile serrated lesions and mucinous tumors, which have a poor prognosis compared to the left side tumors. And the other important thing to highlight is actually what we call consensus molecular subtypes. Since 2014, if I remember correctly, there is a new molecular subtyping based beyond the standard histology derived from the transcriptome-wide analysis, which looks into tumor microenvironment, metabolic signatures, genomic as well as epigenomic molecular aberrations and other carcinogenic pathways, and then subsequently classifies based on into 4 classifications: CMS 1, 2, 3, 4. Unfortunately, these are not widely accepted or widely adopted worldwide. But the important thing is actually it's linked to overall survival, especially in the metastatic cancers. Previously, CMS1, which was microsatellite unstable cancers, had been traditionally been identified as a poor prognostic cancer. But recent evidence is actually they do well with the immune checkpoint inhibitors. So even though it is not universally adopted, not used everywhere, but probably more adoption means used, then probably the linkage to care, subsequently, the more treatment can be tailored based on the CMS type P. There's also other entity called immune score in CRC prognosis. This is again not well used. It scores actually based on CD3 and CD8 positive T cell tumors in the center as well as the margin. And higher immune scores are correlated with a lower risk of recurrence. As I mentioned, unfortunately, these are not widely adopted in our clinical settings. So looking at the diagnosis in terms of clinical presentation, colorectal cancer can present in 3 different ways. Either person can present as an emergency in terms of bowel obstruction or a GI bleed, or they can be asymptomatically identified on a screening scope, or sometimes some people come with some typical symptoms. So because this is a very slow tumor, so that most of the diseases patients are asymptomatic until it reaches advanced stage. The typical symptoms that they present include hematochezia or melena, abdominal pain or otherwise unexplained iron deficiency anemia, or a change in bowel habits, more commonly the diarrhea rather than a constipation. And the less common presentation include is if the disease advances, the abdominal distension, nausea, vomiting, suggestive of a bowel obstruction. And iron deficiency, as I mentioned, may be unrecognized blood loss especially in the right-sided colorectal cancers. So the diagnosis is mainly based on histological examination of a biopsy that is either most commonly through the GI endoscopy, colonoscopy or a flexible sigmoidoscopy, or from a surgical specimen. Colonoscopy is the most accurate diagnostic test to localize because it can biopsy the lesion, remove if the early polyps as well, identify if there is a synchronous neoplasm, or if there's a polyp, then it can be removed as well. Synchronous colorectal cancers is the ones that defined as if there is a 2 or more distinct primary malignancies that develop within 6 months, separated with a normal bowel. It occurs in around 3% of cancers, especially if there is a synchronous cancer, then there should be suspicion for Lynch syndrome or other mutations like MUTYH associated polyposis. Looking at imaging, mostly the imagings are used for staging, especially MRI in rectal cancer to local regional staging to identify the extent of the tumor, so that whether the resection margins are, whether the tumor is amenable for resections or not. So this will guide for further treatment. MRI also can be used in liver metastasis to identify the lesions. The role of CT scan is for distant metastasis, CT chest, abdomen, and pelvis. CT also has other roles. CT colonography is a complementary imaging method in diagnosing polyps as well as colorectal cancer, especially if there is an incomplete or inadequate colonoscope. However, the CT colonography is used as a tier 2 screening method. Looking at laboratory investigations apart from the complete blood count, all guidelines recommend doing a CEA level at diagnosis. Elevated CEA is associated with a poor prognosis, and especially if it is elevated, post-op monitoring is required. Persistent elevation may indicate that there is a residual tumor. If it has normalized post-operatively or after treatment, that this suggests that treatment is effective. It can be monitored subsequently as well. Looking at pathology, histopathology is, as I mentioned, the basis for the diagnosis. Apart from the staging, for TNM staging, histological subtypes also is there. On top of that, there should be also the assessment of whether there is a lymphatic, perineural, or venous invasion. Also looking at immunohistochemistry to check whether if there's a mismatch repair or if immunohistochemistry staining is not available, some laboratories, or if they are inconclusive, then PCR can be done for the mismatch repair as well. Also, immune score is used for prognostication, as I mentioned as well. And currently, I think universally the mismatch repair testing is used, especially to identify Lynch syndrome, even in sporadic cases as well, because it has implications for those with a metastatic cancer who would benefit from immunotherapy. Looking at natural history and staging, colorectal cancer, as I mentioned, is a very slow tumor. It begins as a intramucosal epithelial lesion, usually start as a polyp or a gland, and then subsequently the cancer grows and then it becomes invasive. It subsequently penetrates the muscularis mucosa and then invades the lymphatic as well as the vascular channels and involve the regional lymph nodes and subsequently adjacent structures and then distant metastases. More often, it's a very long silent disease until advanced symptoms are there. It can estimate approximately around 17 years for a large benign tumor to evolve into advanced cancer, and then subsequently 2 years for cancer that acquire ability to metastasis. So the pattern of the spread depends on the location of the tumor and its lymphatic as well as blood vessels. Cancers of the rectum advance locally by progressive penetration to the bowel wall. Extension of the primary tumor intramurally and parallel to the long axis of the bowel is most often limited. And lymphatic or hematogenous spread is unusual before it penetrates the muscularis mucosa. However, in poorly differentiated tumors, it can metastasize via the lymphatics even before it penetrates the bowel wall. Because the rectum is relatively immobile and it lacks serosal covering, rectal cancers that tend to spread continuously to progressively involve local structures. Based on the blood supply, lower third of the rectum, it can either metastasize via the portal vein to the liver or through the middle hemorrhoid vein and inferior vena cava to the lungs. On the other hand, upper in the middle third of the rectum, it drains into the portal system and subsequently to the liver, and the subsequent metastasis to the lung is through the liver. Similarly, colon cancer can invade transmurally and involve regional lymphatics and then subsequent distant lymphatic lymph nodes. The lymphatic drainage generally parallels the arterial supply to a given bowel segment. Liver is the most common site of spread, via the portal venous system from the colon cancers, and pulmonary metastasis usually, as I mentioned, comes from the hepatic metastasis. There is a TNM stage that looks at the primary tumor and then lymph node as well as the distant metastasis. The T accounts for the extent of the tumor, and then stage 1 is the cancer that is usually limited to the submucosa, stage 1, and then stage 2 is the cancer that invades through the muscularis propria into pericolonic collection, but it has not metastasized to involve the adjacent peritoneum or the nodal metastasis. Stage 3 is any degree of bowel penetration with a regional lymph node metastasis, and then there are subgroups as well. And then stage 4 is any cancer that involves the bowel wall, any invasion of the bowel wall with or without lymph node metastasis, but it has evidence of distant metastasis. If there's a one organ involvement, that is M1A. If there's more than 2 organ involvement, that is M1B. Then management of the colorectal cancer. Look, if the cancer is diagnosed early on, some cancers, if it is identified, especially T1 cancers, that can be managed endoscopically if it is just a local tumor. But these malignant polyps should be resected en bloc depending on its size, either endoscopic mucosal resection or submucosal dissection, or full thickness resection can be done. But however, the most important thing is actually this is should be done in expert centers with skills, because those who are not experienced should not be, should be done by, advanced endoscopists with a good experience with great centers. But the important thing is actually letting the patients know that if it is a local small tumor which is not metastasized, or if it's just limited to T1, so if it can be amenable for resection, those can be done endoscopically rather than going for surgery. Looking at a surgical treatment, the approach is actually complete mesocolic excision, which means actually sharp dissection along the embryological planes with the mesofacial interface. Usually, worldwide, the laparoscopy is the laparoscopy is used, and because it has short-term benefit as in some randomized trial as well as population studies. Surgery for rectal cancer is more complex, but related to accessibility of the tumor because of the anatomy of the pelvis. It is actually total mesorectal excision is the standard endoscopy oncological approach. And again, extent of the resection further depends on the involvement of the sphincter complex and other surrounding structures as well. Again, this is also when done, I think some evidence shows that laparoscopically it can be done as well. So these are various surgical resection that can be used for colorectal cancer resection based on the primary location of the tumor. So as I mentioned, colorectal cancer can present as an emergency with a bowel obstruction or perforation. In obstruction, in an emergency setting, decompressive colostomy or endoscopic stenting can be used. But the important thing is actually in patients who are stenting, if stenting is done, it should be a multidisciplinary decision, since it can limit the later use of NTV, vascular growth factor drugs, because they have, if stents are used, there is a risk of perforation in these patients. So radiotherapy for rectal cancers, preoperative radiotherapy is used, proven to reduce the local recurrence risk. It's shown to be better than the postoperative radiotherapy. It's tailored based on the MRI staging. Chemoradiotherapy is most often used. The standard dose is around 45 to 50 gray in 25 to 28 fractions with fluoropyridine as a radiosensitizer. It achieves around complete response in some 15 to 20% of the patients. Hence, sometimes the patients can be, can be just managed with the chemoradiotherapy without needing a further surgery with what we call as wait and watch approach. Time to surgery is usually after the radiochemotherapy. Its common practice is 8 to 10 weeks, but again, it can be varied depending on the experience of the center or whatever the onco. Usually these decisions are done by tumor board meetings. There is a rectal preserving treatment, as I mentioned, watch and wait approach. It actually, concept is actually omit surgery altogether because by giving chemoradiotherapy. But important thing is if there is a complete clinical response with chemoradiotherapy, the patient should be monitored closely, because with close rectal examination, endoscopy, as well as MRI. And if there is evidence of recurrence, then patient should still be, surgery can be still offered for these patients. Looking at a systemic treatment, the adjuvant chemotherapy is actually fluoropyrimidine-based chemotherapy. It improves survival, especially in stage 3 and stage 2 high-risk cancers. Nowadays, oxaliplatin is added after the pivotal Mosaic trial. It actually combination, it has shown to be improved, but the main concern is actually cumulative sensory neuropathy, especially after 3 months of oxaliplatin. So there are some evidence coming that if it is a low-risk cancer, the duration of the chemotherapy can be shortened for 3 months instead of traditional 6 months. And in stage 2 tumors, the presence of dMMR is a good prognostic. It does not benefit from adjuvant chemotherapy. Systemic therapy for metastatic colorectal cancer is actually, there are two approaches, whether this is a curative approach or palliative. If it is an oligometastasis, then the approach is curative. And if there is a widespread metastasis, then the approach is palliative. Then the role of chemotherapy is again downsizing the tumor and to reassessing whether the patient can subsequently go for local treatment or surgical intervention, depending on whatever the response is. And looking at the chemotherapy regimens, the backbone is actually, as I mentioned, fluoropyrimidine, oxaliplatin, and irinotecan. The 2 or 3 drugs are combined, and biologics are used depending on the tumor biology, whether vascular growth factor, anti-vascular growth factor, or anti-EGFR antibodies are used, but I don't know how much is available here. And again, these decisions are done by a multidisciplinary board from usually a tumor board. So those who undergo treatment or have a cure, then there is a surveillance that we have to follow these patients with a strict surveillance, given that these patients can develop a second cancer, or recurrence of the cancer, especially within the first 5 years. In stage 1 disease, the colonoscopy is usually year 1, 3, 5 post-surgery. And stage 2 and 3, there should be clinical assessment, CA level every 3 to 6 months, and then subsequently 2 to 3 years, and then biannually until 5 years. For these patients, again, colonoscopy is for year 1 and then every 3 to 5 years. CT scan, cross-sectional imaging is also done every 6 to 12 months for 5 years for these patients. Stage 4 cancer, after the post-metastatic resection, this patient should be on a very close surveillance, given that higher recurrence risk is there for these patients. In terms of prevention, the prevention can be either primary, secondary. The primary prevention refers to the identification of genetic or biologic risk factor or environmental risk factors that are associated with the colorectal cancer, and then trying to alter then prevent the disease even before the development. So the certain risk factors like lifestyle changes, including smoking cessation, daily exercises, healthy diet, are the lifestyle changes that can be used as a primary prevention. Similarly, chemo prevention has been discussed. Vitamin D supplementation, calcium, hormone replacement, as well as a low dose of aspirin and NSAID. But again, this is a controversial area with limited or conflicting evidence. But these are some evidence suggests that they do prevent cancers, but there's not strong evidence to suggest on a regular basis to use aspirin and NSAID as well. So looking at a secondary prevention is the early detection and treatment of precancerous or cancerous lesion to improve the prognosis. So there are various cancer screening methods that can be used. Colonoscopy is the gold standard because it can detect as well as remove the lesions, especially in high-risk individuals. The screening method recommended is actually colonoscopy. Those who have hereditary risk factors, those who have prior adenomas, and those who have high-risk conditions like long-standing IBD, they need regular surveillance with colonoscopy rather than the non-invasive blood or stool testing. Other tests that can be used include stool tests like fecal immunochemical test and DNA-based test. But then if there is an identification of positive test, then subsequently the colonoscopy should be used for Other tests include sigmoidoscopy, but which only looks at the left side. It also reduces the incidence and around 16 to 26% in some studies, and then mortality reduction is also reduced by 20 to 30% in low participation. But however, given that there is also an invasive method, participation rate is also low. The other screening method can be CT colonography, as I mentioned earlier, which is also somewhat cumbersome, given that it also needs a bowel preparation and then insufflation of air or carbon dioxide to inflate the colon, and then subsequently doing the colonoscopy and then reconstructing the all images to identify polyps or any cancer. If there is an image polyp or lesion identified, then subsequently needs a colonoscopy. However, even given the participation rates are low and the somewhat cost-effective or logistic issue is on a large scale, that it's challenging. There is also some newer evidence coming, even though not recommended, the role of circulating tumor DNA. I think recently published in New England Journal of Medicine that looked at the sensitivity and specificity of the circulating tumor DNA and detecting colorectal cancer was around 83% compared to the colonoscope. And then identifying, however, the precancerous lesions were very low, like 13.2, and then early stage cancer was only 55%. This diagram actually looking at the sensitivity, specificity of various screening methods that can be used for colorectal cancer screening, and their risk may reduce impact on the reduction on colorectal cancer death. As you can see, colonoscopy is the gold standard. But when we determine the patients for colonoscopy or risk screening, we should be first identify or risk stratify the patient, and then subsequently do the subsequent screening methods can be used. Like those who are at increased risk, patient with first degree relative defined as a parent or sibling, or a child who has a cancer, or particularly before age of 50 years, should be considered as a high risk for colorectal cancer. And these patients should be doing colonoscopy as a screening rather than other methods. And individual average risks are those who have a personal history of colorectal cancer, inflammatory bowel disease, or hereditary colorectal cancer syndrome, other predisposing conditions. These patients should also be going for a colonoscopy. But then the frequency and the timing of colonoscopy varies these patients. As I mentioned, those who have a increased risk, the screening recommendation based on the AGA statement last year, it should be from colonoscopy should be started at the age of 40. Supposing if there is a family history of first degree relative with the cancer, they have a higher risk of colon cancer. Hence, these people should be undergoing screening colonoscopy at the age of 40 or 10 years younger than the age of the first degree, 10 years younger than the one who, supposing the first degree relative had a colon cancer at the age of 40, then these people should be undergoing colonoscopy screening at 30 years of age. Or if there is an average risk, then there is the usual recommendation is more than 45. They can do the first screening colonoscopy followed by every 10 years. Thank you.
So, Muaz, thank you very much for that overview of colorectal cancer. I think it was an excellent presentation. Is there any, let's go to the chat. If there's any questions, you guys can type it into the chat. So, well, just two questions from my side. Obviously, in terms of the risk factors of colorectal cancer, we've got obesity, and associated with obesity is diabetes and insulin resistance, etc. From your reading, have you come across any benefit in terms of the GLP-1 molecules in terms of reducing colorectal cancer risk, or etc.? Because that's commonly what they use now for the obesity, etc.
Unfortunately, I did not look into that aspect, but theoretically speaking, given that GLP-1 is associated with, very effective in obesity, I assume that insulin sensitivity would ultimately lead into the reduction of, I mean, colorectal cancer. But I did not completely look into that aspect.
Okay, yeah, I know. So there is data that's showing that the GLP-1 receptor antagonist may reduce the risk of colon cancer in people with type 2 diabetes, and especially those that are overweight and obese. So that's a new armamentarium or therapeutic arm that we can look at. Then something before that. What about the role of aspirin in terms of colorectal polyps and then cancer?
Means some studies have shown that it is benefit, but then because there is some conflicting, because theoretically with NSAID as well as aspirin, the pathway is actually because of it blocks the COX-2 and then promotes apoptosis. So there is a reduction of polyp or colorectal cancer reduction, but it's not consistent. So the recommendation is if there is no other metabolic risk factor that because there are
Why is
associated
aspirin?
risks. So unless there is an other indication, then aspirin is not routinely recommended.
And I think that's an important point because obviously the risk with aspirin and GI bleeding is very, very serious, which we as gastroenterologists usually do see. There's a comment on the chat that says the traditional serrated pathways differ from sessile serrated lesion pathway. The former involves two distinct pathways, one characterized by the BRAF mutations and the other by the KRAS mutations. Although both pathways produce MMR proficient cancer, the KRAS mutated type does not respond to cetuximab, which is obviously we spoke about that earlier in terms of those checkpoint inhibitors. Okay. Then there's a question that comes through with regard to screening. So obviously, in the past we would screen patients with first degree relatives. And I see the AGA guidelines said that now the screening should be at least 10 years earlier than the person that had a primary cancer. So the new guidance recommends screening should be started at the age of 40 among the average risk individuals. What's your thought process regarding screening and for colorectal cancer in two parts? In one, the average risk patient and somebody who presents to you to says, I want a full medical done, including a colonoscopy. I'm 40 years old. I've got no risk factors. So the first group is an average risk patient, and the second one is somebody who just wants a colonoscopy to be done in a resource limited setting. What do you think?
I mean, if there is, if resources allow me, I would be going for colonoscopy. But then I would also be looking at if the other parameters like if the further history, looking at the change in bowel habits as well as other biochemical anemia as well. But having said that, because nowadays there is an increase in risk, incidence of early onset colorectal cancer, especially in the younger population, even though the latest recommendations are for 45 to 40, the more concerning and especially the poor prognosis is seen in those who are younger. So if somebody requests ethically, I would be inclined to do
And
screening.
I would agree with that. My youngest patient that I've got with colorectal cancer was 12 years old. So it's a reality, and sometimes we tend to be a bit conservative to do colonoscopies, but it's something that one needs to consider, especially in the right age group and the right patient that you are going to see in front of you. So the next question is regarding therapy. So obviously we've got a combination of either chemotherapy, radiotherapy, and thereafter surgical therapy. And you've outlined it quite nicely as to which group would benefit from which type of therapies. In your experience, what has your experience been with some of these patients? Do you chat a lot to the oncologist, and do you deal with patients that are post surgery?
Unfortunately, our practice here is actually most of our role is actually regarding the diagnosis.
Hmm.
So at the moment, because during our colonoscopy, once we diagnose the patient, we just send over to our colorectal colleagues, and then there's usually in their multidisciplinary team meet board meetings, and they with oncologists, then subsequently they manage the cases. Of course, then some patients who had a cancer, then they do come for subsequent surveillance colonoscopes to us as well.
Okay, so I think a couple of important points with regard to that is that when we're doing diagnostics and we come across somebody with a colorectal cancer, it's very important to obviously try and extract as much tissue as possible at that moment. Take good biopsies at that time. If there's an associated polyp or anything at that time, try to remove it to look for synchronous cancers, etc. Because the more information that you provide to the pathologist, together with adequate radiological imaging, the better will be your outcome in terms of a therapy, because then the oncologists have got a lot more to work with, including the surgeons as well. The Obviously, colorectal cancer is increasing, and a lot of it is increasing because of our dietary and lifestyle changes. We spoke about high temperature based foods. We spoke about lack of fruit and vegetable, dysbiosis, the gut microbiota, etc. Is there any difference in terms of racial profiling for patients that have got colorectal cancer among, for example, Caucasians or predominantly African people? Have you seen a difference in the type of cancers, etc.? Do you know?
I'm not sure. I'm not so
No.
sure about that.
Okay,
But
so obviously,
obviously, I think the me if I remember correctly, maybe in the US, I don't know how much of data here is in the Western world. I think in the US, I think probably in the me African Americans, I think they have usually the poor prognosis, probably because of the late diagnosis. I'm not sure about the biology though. Probably because of the me access to healthcare as well as those things probably.
absolutely. And also, here in our setting as well, I work in the Baragwanath Hospital, where there's predominantly much more African patients that are there compared to perhaps maybe Johannesburg Hospital, which may have a little different scenario. But I can tell you that from experience, we're seeing a lot of young men that have got rectal tumors. Some of them, are HIV associated, but a lot of them are actually not HIV associated. And these are young men that have got low-lying rectal tumors, and they present with rectal bleeding. And because they are young men with a history of intermittent constipation, sometimes there's a very low threshold not to do a scope on them, and those guys are actually just labeled as being having hemorrhoids or piles without us actually doing a formal examination. So I think one of the learning points or take home points from a colorectal talk is do a per rectal examination on every patient that has got bleeding. It's criminal not to do that, not to examine the perianal area, because you may find a tumor that is so low lying and within your fingers reach, you are able to reach it. And unfortunately, we don't do that. It's a basic test which should be done. And these patients go on and they present later on with much more complications. So, yeah. Is there any other questions from anybody else? I'll just go through the chat and just see if there is something here. But yeah, I think that kind of settles it up. Okay, all right. Moaz, once again, I think it's yeah, almost 5 to 7. Any last comments from yourself?
Yeah, I think my important thing is also, as you mentioned about the I wanted to highlight is actually regarding the early onset colorectal cancer, because given it's a malignancy, even if the patient, elderly people with the change in bowel habits or any symptoms, we tend to have a lower threshold for colonoscopy and examination. But if supposing young patient presents with the similar symptoms, even if we consider as a benign pathology, we should reassess soon enough so that we don't miss the diagnosis. Some of the patients, as you mentioned, who are labeled as a hemorrhoid or whatever, or diverticular disease or bleeding from the diabetics, and they may be actually having colorectal cancer. And given that early onset colorectal cancer has a different somewhat biology with more aggressive phenotype, they need to be identified early on. Unfortunately, given the low suspicion in the younger population, they are diagnosed with late.
Absolutely. And I think also sometimes younger people may also just out of fear or embarrassment not tell you that they have got rectal bleeding or not tell their loved ones, etc., that this is the problem that they're having. And as a result, it also may lead to delayed in diagnosis. And just one last comment is obviously now with the advancement of advanced endoscopy, early colorectal cancers can obviously be treated endoscopically, therefore decreasing the need for much more invasive surgery, etc. So that is something that one should also, consider if in the right hands and the right expertise, etc. So thank you very much, and we'd like to end this by saying that thanks to the presenters, thanks to Echo UNM and Echo India team for the support. Fortunately, this has been recorded, and thanks again to the Gastro Foundation for making this possible. We really appreciate it. Thank you once again, Moaz. Okay,
Thank you.
goodbye.
Bye.